The presentation today is on implementing personal protective equipment in nursing homes to prevent the spread of extensively drug-resistant organisms, or XDROs, and multi-drug resistant organisms, MDROs. Introducing enhanced barrier precautions. The objectives for today's webinar are to review the difference between colonization and clinical infections, review standard and contact precautions, and introduce enhanced barrier precautions, describe the impact of multi-drug resistant organisms in long-term care facilities, identify appropriate personal protective equipment, or PPE, to use for each precaution based on the type of activity being performed, and examine when room restrictions are warranted. First, we're going to review the basics. Colonization. Microorganisms, bacteria or fungus, are present on or in the body but are not causing disease. Bacteria or fungi are present without evidence of infection. Infection is an active process where the microorganisms are causing harm to the body. Bacteria have grown and person is displaying symptoms from them. Standard precautions are to be used with all residents. Standard precautions are a group of infection prevention practices that apply to all residents and patients, regardless of suspected or confirmed infection status, in any setting in which healthcare is delivered. Standard precautions are based on the principle that all blood, body fluids, secretions, and excretions, except sweat, may contain transmissible infectious agents. There are different standard precautions: hand hygiene, use of personal protective equipment, respiratory hygiene or cough etiquette, sharp safety, safe injection practices, sterile instruments and devices, and clean and disinfected environmental surfaces. This presentation will focus on the use of personal protective equipment. Use of personal protective equipment is based on the staff interaction with the residents and the potential for exposure to blood, body fluids, or pathogens. Example is gloves are worn when contact with blood or body fluids, mucous membranes, non-intact skin, or potentially contaminated surfaces or equipment when that is anticipated. Why introduce enhanced barrier precautions? Contact precautions alone has failed to control the transmission of multi-drug resistant organisms in nursing homes. Facilities need an approach to gown and glove use that is less restrictive than contact precautions and can be sustained for prolonged periods of time. A category of transmission-based precautions that balances patient-centered care and risk. How do we know contact precautions alone has failed to control the transmission of multi-drug resistant organisms in nursing homes? This is a study done by McKennell et al. In the Clinical Infectious Disease Journal. It talks about the large burden of multi-drug resistant organisms in nursing homes. The study focused on 14 nursing homes. In those facilities, the documented multi-drug resistant organisms were 17% of the residents. However, there were actually 58% that had an MDRO, and of course, all of them were not documented. When we look at a ventilator-capable nursing home, same thing, where the documented MDRO was 20%, but the actual MDRO was in fact 76%. This is showing that this is the 20% is just the tip of the iceberg. We don't know what lies beneath, and we're not always doing something about it because we're only paying attention to the ones that are documented. Why has contact precautions failed to stop the spread? Many nursing home residents are unknowingly colonized with an MDRO, especially those residents with risk factors like wounds and indwelling medical devices. Residents with MDROs remain colonized for long periods of time and can spread the MDROs to others. Unfortunately, MDROs are spread by healthcare personnel through contaminated hands and clothing. Not all healthcare personnel follow procedures appropriately for transmission-based precautions, and consequently, they are transferring the MDROs from one resident to another resident. Enhanced barrier precautions, or EBP, balances person-centered care and risk. What do we mean by person or patient-centered? The residents need to socialize and participate in communal dining and group activities. Isolation is scary, and it can be stigmatizing if required to stay in their room and not come out. Residents on enhanced barrier precautions are not restricted to their rooms and may leave their room to participate in communal dining and group activities. What do we mean by risk? Does the resident have an indwelling medical device, an open wound, or are they immunocompromised? Enhanced barrier precautions helps protect residents at risk for acquiring colonization, those with wounds and dwelling medical devices. Now let's take a look at the categories of transmission-based precaution, explaining the difference between contact precautions and enhanced barrier precautions. This webinar will not go into airborne or droplet precautions, although they are types of transmission-based precautions. Transmission-based precautions are for residents who are known or suspected to be infected or colonized with infectious agents, including certain epidemiological important pathogens, which require additional control measures to effectively prevent transmission. Transmission-based precautions are intended to prevent transmission of infectious agents, including epidemiological important microorganisms, which are spread by direct or indirect contact with the patient or the patient's environment. What are enhanced barrier precautions? Enhanced barrier precaution expands the use of PPE beyond situations in which exposure to blood and body fluids is anticipated. Enhanced barrier precautions falls between standard precautions and contact precautions on the continuum of care. EBP requires the use of gown and gloves when performing high contact resident care activities. Gowns and gloves are not required when you are not performing a high contact activity. EBP offers better protection for the resident, prevention of colonization or infection, and it's intended to be used during the resident's entire stay or until the wound heals or the medical device has been removed. What are high contact resident care activities? Dressing, bathing or showering, transferring, providing hygiene, changing linens, changing briefs or assisting with toileting, device care or use, that would be urinary catheters, feeding tubes, tracheostomies, ventilators, and central lines, and wound care, those wounds that require a dressing. Enhanced barrier precautions, what's required? You need to post a sign on the door frame and above the bed if the resident should reside in a multi-occupancy room. Hand hygiene should be performed every time you enter the room and at exit. Gowns and gloves are required every time with high contact activities. Residents may participate in communal dining and group activities, and a private or single room are not required. And the focus, or the one thing to take away, is we're trying to prevent the transfer of organisms to staff hands and clothing. Contact precautions. Today, we're going to talk about the old contact precautions versus the new contact precautions. In long-term care, this will be a paradigm shift. The way that you were doing contact precautions will now look different. The old contact precautions in long-term care often allowed residents to come out of their rooms and participate in communal dining and group activities if the wound or drain could be contained. The new contact precautions, residents will be required to stay in their rooms unless medically necessary to come out, and the resident should not participate in communal dining and group activities. Contact precautions should be used for all residents with draining wounds that cannot be contained and/or diarrhea, regardless of the MDRO status. Contact precautions should be used on units or in facilities where ongoing transmission is documented or suspected, and for infections such as C. diff, scabies, norovirus, and other conditions where the CDC has recommended contact precautions to be used. What's required for contact precautions? Again, you must post the sign on the door frame. Each bed should be treated as a private room in multi-occupancy rooms. Hand hygiene should be performed every time upon entry and exit. Gowns and gloves should be worn every time for all resident care. You should attempt to dedicate or use equipment or use disposable equipment. Communal dining and group activities are not allowed. Dining and activities should occur in the residence room only. And a private or single room are preferred. You may cohort like organisms following the cohorting guidance and consult with your local health department. How do you determine what type of transmission-based precautions to use? There is a statement from the CDC in implementation of personal protective equipment use in nursing homes to prevent the spread of multi-drug resistant organism. In that guidance, there's a statement that needs to be emphasized. It says MDROs for which the use of EBP applies are based on local epidemiology. At a minimum, they should include resistant organisms targeted by the CDC, but can also include other epidemiological important MDROs. When determining which type of transmission-based precautions to use among residents, facilities should consider using one or more of the following approaches, keeping in mind that standard precautions should be used on all residents during all care. The two approaches are pathogen-based and risk-based. What do we mean by pathogen-based? XDROs. Enhanced barrier may be used for residents with an XDRO unless the resident has draining wounds that cannot be contained and/or diarrhea, in which case contact precautions would be indicated. Should the resident have an MDRO, facilities should use a risk-based approach to determine what type of precautions, if any, are warranted for a resident that is colonized or infected with an MDRO. A risk-based approach takes into consideration the resident's clinical situation, the prevalence or incidence of MDROs in the facility. Consider this approach for residents with organisms not previously encountered in the facility. A risk-based approach looks at one, uses enhanced barrier for residents with wounds requiring dressing. We're talking of pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, and chronic venous stasis ulcers. Unless the drainage from the wound cannot be contained, or the resident is colonized or infected with an infection or condition listed in Appendix A of the CDC isolation precautions, where contact precautions would be recommended. You may use enhanced barrier precautions for residents within an indwelling medical device, such as a central line, a urinary catheter, a feeding tube, dialysis catheter, a trach, or a ventilator, unless the resident is colonized or infected with an infection in Appendix A, where contact precautions are recommended by the CDC. What type of wounds are we talking about when we say wounds requiring dressing? CDC does not typically include a skin break tear that would be covered by a Band-Aid or another type of dressing similar to a Band-Aid as a wound requiring a dressing. CDC considers the following as wounds requiring a dressing: pressure ulcers, diabetic foot ulcers, unhealed surgical wounds, other wounds such as chronic venous stasis ulcers. On the unhealed surgical wounds, these are surgical wounds that are not healing. This is not a fresh post-op surgical wound for total joints, etc. What types of medical devices are we talking about when we say indwelling medical devices? CDC defines indwelling medical devices as those that communicate to the outside. CDC would not classify a dialysis fistula as an indwelling medical device if it has healed, but it does include hemodialysis catheters that have direct access to the outside. The following are considered indwelling medical devices: central lines, urinary catheters, feeding tubes, hemodialysis catheters, tracheostomies, and ventilators. An ostomy or a stoma, fresh or mature, are not an indication for EBP. Facilities, how should they go about implementing EBP? Provide education to your staff and make sure they are trained. Validate the competency of staff on PPE use for enhanced barrier precautions. Start slow, perhaps start on one unit and ensure everyone understands the principles before moving to the next unit. Or select a unit that has a higher burden of XDROs or MDROs, or a unit where ventilators or trach residents reside. And consider using the CDC pre-implementation tool for enhanced barrier precautions to access readiness. These are the resources listed on this slide. If you have questions, contact your local health department and regional IDPH infection preventionists. This webinar is provided by the Illinois Department of Public Health. Thank you.